Good afternoon and welcome to the Quest Diagnostics sponsored webinar, 7 Overlooked Opportunities in the Revenue Cycle. My name is Colby Dix and I will serve as your moderator and host today. We have a lot of material to cover in this hour and we're very pleased to have Elizabeth Woodcock with us to discuss these 7 overlooked opportunities. Our overall agenda for today is on the screen for you now. We will dive directly into Elizabeth's presentation shortly, and there will be a Q&A session directly following. Please also stay with us for a brief overview of Quantum's healthcare IT portfolio to close out the hour. Extend a warm welcome to our presenter today, Elizabeth Woodcock. Elizabeth's bio is up on the screen now, and you can see that we're very lucky to have someone with such experience available to us. Her extensive publications and years of dedication to healthcare IT have earned her great renown in our industry. As the founder of Woodcock & Associates, she's consulted with clinicians and practices nationwide. Welcome, Elizabeth.
Colby, thank you so much for the introduction, and thanks to all of y'all who are on the line with us today to hear our program, 7 Overlooked Opportunities in the Revenue Cycle. It's truly an honor and a privilege, and I do want to express my appreciation to Quest Diagnostics for sponsoring our webinar today. I think that you're going to get a great return on the investment of your time. I mean, look at this agenda. We're going to start off looking at charge capture, Workqueue Management denials, and I know you may be like, oh, Elizabeth, we do all of those in our business office, but let's take a fresh view. Because what I want to take a deep dive into is those opportunities. Yeah, the processes, everybody does those, but where are we missing the boat? Where may we find that, oh, let's pull up that rock, overturn it, whoa, there's the money. I love billing and collections because there is a very, very tight correlation to dollars in the door. So I want you to put your thinking caps on. Let's make sure we get some ideas and create an action plan from those ideas following your investment of time in our webinar today. Now, you may say, well, I've done that, I've been there, I'm a radiology group or I'm a family medicine practice and I don't like this idea, and that's fine, but I'm going to ask. I'm going to ask that you come up with 3 ideas you feel you can take action on. I think you're going to find a lot more, but again, 3 ideas that you feel you can take action on to really, really get a great return from your time. Let's start off with charge capture, indeed. Now, charge capture has sort of become like, my EHR does it, no worries. But I want to hone in on 2 areas that I see overlooked time and time again. The first one actually has to do with the leveling of the E&M code and the decision regarding established or new patient. So look at this study. It was done a number of years ago, but I find it very interesting. We handled 3.05 problems per patient visit, but recorded, documented only 2.82, and then, whoa, billed for 1.97. So here's the issue. We may be taking a look at our EHR system supporting us in terms of leveling the code. We may be taking a look at, indeed, coders that are coming through and reviewing the notes and saying, well, let me offer a suggested E&M level based on that. My problem, the overlooked opportunity is in the first bullet, the handled. I find that there is a significant gap between what the physician actually performs, what he or she handles or manages, and what he or she documents. And unfortunately, all of the ways that we capture the level of an E&M code depend on the latter. Now, I'm a coder, all that kind of good stuff, and I know you're saying, oh, Elizabeth, goodness gracious, please remember, if it's not documented, it's not done. And I completely agree with you. But what I got to have you do is not just take a look at the documentation, but get in there. Get in that exam room and really, really help physicians understand not just what to code, but what to document. Huge overlooked opportunity that we have absolutely no processes to support. And I'm talking about pretty big dollars. Let me just go over some just really quickly here on slide number 3. We've got an established patient visit level 2. Our 2017 just non-facility Medicare allowable, that's a national rate, is $44 and some change. We level that 2 up, and we are looking at a $64 gap. I mean, that's huge. I'm not talking about a different patient. I'm not talking about making sure that you've added some ancillary service. I'm just talking about the office visit itself. And then allow me to leapfrog into, well, let's take a look at an established versus a new patient visit. There's another $60, or as you can see, $57.42. If I have not seen that patient in my specialty in 3 years, in my specialty, and that's a real key aspect. Specialty, of course, defined as taxonomy code. So even within some specialties, like cardiology, for example, once I flip to a different subspecialty, if it indeed has a different taxonomy code, then I move into a new patient status. And again, there it is, $57 and some change. So these are very important variables that really, really require scrutiny, require analysis. But if you just found two patients a day, seeing patients 4 days a week, you are talking about $25,000 in profits. Now, this is important because, remember, oh, my goodness, you've already paid the landlord, right? You've paid the IT, the malpractice insurance. What we're talking about here is not charges. What we're talking about here is truly revenue that has no expense associated with it. So even if you could find one, maybe even one a week, you're talking about a great contribution to your practice. So again, let's focus on handled, not just documented. Get in that exam room, shadow the physician, help him or her understand the handling, and be sure you follow the new patient rules correctly. Now, when we used to key in all of our own charges, of course, we all had, in fact, I was out there saying, absolutely, we got to key them in, got to make sure, right? Time is not on our side. And part of that was because, oh my goodness, I mean, have y'all ever found charges, super bills, or encounter forms sitting in a drawer? I have found stacks of them, right? And so we needed some way to say, you know, every day we got to get these charges in. So we were on an absolute timing mechanism. Get them in, get them in, get them in. So we've got two issues, though, not only timeliness, but we also have accuracy. And my fear is between our EHR system and our push to make sure all of our charges get in, and normally it's on a same-day basis, if not next day, that we're losing quality. And I just spoke about the leveling and the new patients, but indeed, when I think about quality, I'm also considering, hey, what services were performed? Smoking cessation counseling, for example, no cost sharing for Medicare patients. You can actually do multiple attempts per year, right? So you may have performed the actual service, maybe even have documented it, right? That's my sort of preaching is let's make sure we document it. But even if we documented, hey, we still got to make sure that we get that code into our Medicare contractor. So let's make sure we have a charge reconciliation protocol that avoids any leakage. The leakage, of course, means services that your physician performs that we don't actually capture and bill for. Now, I normally find that office visits, and that's sort of why we're like, I mean, really, no big deal. Office visits taken care of, right? We line up the schedule. We do our cute little missing charges report. We say we saw 23 patients in the office. We got 23 charges. So I'm talking about digging deep. And if you think that giving a physician a little app on his or her smartphone is going to take care of this all, you need to think again, because it still has to get from his or her brain into that app. So in my opinion, not only do we need good charge capture mechanisms for everything we're doing in the office as well as out of the office, but once we move outside of our practice walls, we need to have, indeed, primary source documents to reference. It might be the labor and delivery log, the operating room log, the dialysis center may send over the patients either per day or, of course, per month. Some sort of primary source document whereby you, even if it's manual, I mean, ideally here, of course, it's automated, but you are making sure that you are checking, you are confirming that all services are indeed accounted for and billed for. You'll be amazed. You think that, oh, I'm not doing this, I don't need to worry about it. I'm just asking you to put it on your action plan for just 1 month. If you don't find anything, I totally get it. But if you find one consult, one procedure, one surgery, you're talking about services that were performed. Believe you me, the patient is not going to call you and say, did y'all forget to charge me? Because I'm happy to pay. And neither is Cigna, Aetna, United, etc. Nobody's going to call you. You've got to figure this out on your own. So let's take a look at that. Overlooked opportunity recommendations. Overlooked opportunity number 1, our recommendations are to make sure we understand what our physician is handling, ideally to ask a coder or another resource to make recommendations for documentation. We also want to ensure that we have a closed loop process so that every single service is indeed charged for in our practice. Now let's move over to another aspect that's really changed in the last 5 years as it relates to revenue cycle management. And that is the fact that we've moved away from our big AR reports that we used to print out. You know, they were 1 inch, 2 inch thick. And we also had, you remember those big calendars that we had on everybody's desk, and we would write in, you know, call Aetna the Thursday from next, because we'd called them today. We needed to remind ourselves to call them next Thursday. Y'all know what I'm talking about. And so we've moved from a very manual system of working accounts to one that is largely automated. So my challenge, however, is that we have not brought forth a very sophisticated manner of deploying those work queues or task queues. Oh my gosh, I will tell you that I generally find 50% of the practices that I go into still work their work queues in alphabetical order. Hello. It makes no sense other than thank goodness I'm a W, because nobody's ever going to get to me. So we've got to really figure out how to ensure our work queues are set up properly, because we're losing money. We are losing money based on it. I've got to have a priority based on timely filing deadlines, because if I don't, for example, get to United Healthcare accounts within 60 days, and that's their filing deadline, I don't care whose last name it is, what letter it starts with, or what services were performed. I'm going to have to write it off. The second thing, of course, we want to prioritize in our work queue is dollars. I mean, great, wonderful that you did a venipuncture, lab handling fee. Yay, yay, yay. But the surgery that is $3,000 that's at the back of the work queue not getting work, and the $3 charge is, you're crazy. So you might say, oh, no, we don't do this. But I am floored by the amount of employees that do not know how to methodically, systematically prioritize their work queue. Please go take a look at it. Of course, as a sub-work, we can sort by payer as well as by service, so that could give us some opportunities if we call, for example, Anthem, and we're really looking at this one spine surgery that we've been doing over and over and over again, then we can ask about those 4 or 5 accounts. But again, timely filing and dollars should really be our priority. Now, another problem that we have, particularly with account follow-up, is we do have a number of what I consider to be professional highlighters. These employees are employees, and just give you a scenario, I met one years and years ago when I first started consulting, and indeed, she literally had, I was just so amazed when I saw this picture because this is exactly what she had on her desk. She pulled out this nice little wooden thing. It had little holes in it, and I'm like, we're in the business office. What's going on? Right? She pulled this out, plopped it on her desktop, and she plopped down that 1.5-inch thick AR report. Of course, it was sorted in alphabetical order, and she put those little highlighters right in those little slots. And she said, now, Elizabeth, what I do is I take my blue highlighter, and I go through my report, and I highlight all the Blue Cross Blue Shield accounts, right? Get it? Blue and blue. And green was for workers' comp and yellow for Medicaid. And then she whipped out a ruler and a pen, and she underlined all the accounts that were really high dollar. And then she took an asterisk, and the asterisk next to the ones that her supervisor had asked her about. I mean, she had a whole system. So later on that day, I asked her supervisor, now, when does this employee actually start to work every day? And, of course, y'all know what she told me, 2:30 in the afternoon, and that's on a good day. Oftentimes it was 3 o'clock, but did I mention the employee leaves for the day at 4? Well, at least we got 1 good hour of work because the rest of the time that employee is doing arts and crafts. So we have got to engage with our team members regarding not only the prioritization but also the management of work queues. Now, I do believe it's a great idea. In fact, I would consider this a best practice to set a productivity standard for our team members who are working patient accounts. 50 invoices per day is my recommended target. So that's derived based on my experience, but I also, at the bottom here of page 9, place some information based on specialty that MGMA has published. That, of course, is the Medical Group Management Association. You can see the variance by specialty as well as private versus hospital-based medical practice. But 50, as you'll note, is a good rule of thumb. Now, you may change this. Now, the way you may think about changing this is to consider, we have more than one employee who is working account follow-up, and so we're going to take a look not only at refining our work queues and making sure we're prioritizing them correctly, but we're also going to take a look at distribution of skill and expertise. So one of the ways I like to look at this, for example, is by payer. Right? So I might have my government payers being managed by one account follow-up person, and then I may have my non-government or commercial payers managed by the next person. I generally find that's a pretty good 50-50 split if I have included Medicaid and workers' comp on the government side. As we know, Medicare is generally the easiest payer to work with from a revenue cycle management perspective. There are certainly some exceptions, but the rules are known. You get paid pretty quickly, et cetera. But our commercial payers, Medicaid, and workers' comp all give us trouble. So it's a pretty good distribution. But again, this would be up to you because every practice is unique. The other way, of course, we like to take a look at our business office staffing is to understand the work from a functionality perspective. So, for example, if I had somebody who is working some pretty complex coordination of benefits issues, then I would say, you know what, for every 1.5 invoice that employee does, the other employee would be able to do 2 or 3. So the idea behind it is to score invoices. Now, I just gave you an example. As you can see, I would consider workers' comp to be twice as hard as a normal invoice, so the score here is 2 times. So when I break down that 50 invoices, if I've got somebody who's working workers' comp, then that would translate into 25 invoices per day. So you get my gist. The point here is I want you to set a standard related to productivity, refine it either by payer and or by function so that you can establish a realistic target for your team members. Now, you need to take that realistic target and you also need to consider how much work are we actually getting, right? So if I, in my practice, am getting 50 invoices that need to be worked, they're denied. The payer's just not going to pay them. We need to figure out what to do. Maybe it's maybe it's an authorization issue that we overlooked, or maybe there's some crazy credentialing problem with this provider related to one of our payers. If we are getting 50 invoices in to be worked, and you've set the productivity target at 20, and that's what Beatrice is working on. She is only doing 20. You're going to have a problem. You're going to have a big fat problem no matter how you prioritize her work queue or score her task. You're going to have a big problem. Now, this is when Beatrice's desks start to look like this. And y'all, I've seen business offices that look maybe not this bad. Okay, this is a little bit egregious, but pretty bad. Right? You find things stuffed in people's work cubicles. My favorites are those ones that are quite often above the computer station, right? So I've got my little cubicle and I've got that little shelf or that little desk top right there at the top. And so I'm just going to shove more work in there. The more drawers I have in my workstations, the more work I can just pile in because I just can't get it done. And so what happens, of course, is, and I'm not in any way suggesting this is all Beatrice's fault, but if you tell her she only has to do, her standard is 20 a day, and you've got 50 a day coming in, you're going to have a problem, and you're going to have a problem quickly. And so y'all, I'm sure, have had this challenge sometimes in your career in the revenue cycle. You have what I like to refer to as the snowball effect. And you get to this point where you can't manage it, right? So you're like, oh my gosh, should I work the invoices that are really old? Let me do that on Tuesday mornings. And on Wednesday afternoons, I need to work all of the current ones. And then flip, I'm going to go back on Thursday, back to the over 180 days, and then on Friday, well, after I work on the credits, Friday afternoon, I'm going to start working on the currents. And so what happens is you lose the middle. You lose the middle. You're panicked about the old, you're panicked about the new, and the middle just grows and grows and grows. So it's important for us to consider Workqueue management from multiple aspects. I've got to make sure that I am prioritizing and managing it correctly, that I understand how to give a realistic productivity target to my team members, but I've also got to be practical and recognize that in order to avoid the snowball effect, I have to get all of the work done. So I need to have a great understanding of that inbound work. So let's make sure we review our recommendations. Sorting work queues, ideally by timely filing, deadline, and dollar. And then you can also add that service as well as payer. We've got to make sure that our team members have productivity expectations and that we adjust those based on either payer and or function if we feel that that is appropriate. And we also need to make sure that we staff correctly. If we have an expectation regarding productivity that does not match our incoming work, we know we're going to have a problem, and that problem is going to send us into a tailspin that's going to drive up our accounts receivable and is very, very difficult to get out of. So we need to make staff adjustments as needed to avoid that adverse outcome. Now, speaking of adverse outcomes, we know that claims get denied. Right? We can say, well, all day long till we're blue in the face, we want to make sure that the services we bill for get paid. It just doesn't work like that. It's not that simple, as you well know in revenue cycle management. But I got to tell you, many, many physicians sit down with me and they say, why am I not getting paid? And so my absolute recommendation for you is to understand why you're not getting paid, and then to make sure that is transparent, whether you're a billing service or working in-house in your practice, that information is conveyed to your business owners. We've got to know why. Now, fortunately, we do. If you look at the remittances, and I know we don't look at these very often because now they come in electronically, but you got to stop. You want to look at the remittance and you want to understand the group code, right? Is it PR, for example, for patient responsibility? Is it CO for contractual obligation? We need to understand the reason code. This is quite often called a SARC or a CARC because it's the claim adjustment reason code. Why was that service line or claim paid differently than it was billed? And then our payers may offer some additional remarks about the adjudication determination. Fortunately for us, there is one consistent list of these so-called denial codes that is on the Washington Publishing Company website. I've given you the URL right there on slide number 15, so you can either bookmark that or as a team member in the business office, you can have a printout of those reason and remark codes. Instead of getting frustrated about denials, I like to think about denials as our treasure chest. I like to look at denials by all types of cuts and slices of data. Let's look at them by type, by those reason and remark codes, by dollar. We may have just a few services that are being denied, but because they're such high dollar, they're impacting our cash flow significantly. What about date? That's really weird because this health plan started denying claims, and look, we can see before January 1st we have no denials, and after January 1st they're denying everything. Volume payer provider site, we could go on. And I will tell you, my bias is not to look at denials on a quote-unquote claims basis, so not looking at the percentage of claims that are denied upon the initial submission, which depending on the survey you look at is typically between 4 and 10%, but I generally find that it varies pretty substantially by specialty. I like to look at the line item because that's where, indeed, the denials are coming from. You may get the E&M paid, but you may not get, just as an example, the smoking cessation paid. So you, in my opinion, want to drill into your team members' heads. Please, let's make sure we don't look just at the whole claim. We look at individual CPT or charge line items to determine why that service was denied and how we can address it next time. Now, it's important for us to recognize that there are still a few denials coming in by paper. And for whatever reason, maybe it's because we had, some clipboards, or we've got some old out guides that we used to use for our paper record system, or some shelves that has pretty colored blocks on it. I don't know what the deal is, but we have a habit of sending what I used to call in my business office zero pays or correspondence. those paper-based denials, we have a habit of sending those into la-la land. We just put them on a shelf, we file them, we scan them, we put a sticky note, we copy them, but I got to tell you, they need to be placed within 24 hours, like upon receipt. They need to be placed into the same workflow that we have for denials that are coming in on our electronic remittances. This is absolutely crucial because we are losing money because we have some stack over there that nobody's had time to scan, copy, print. I don't know what you're doing with them, but I got to have you stop. Make sure when that paper-based denial comes in that we treat it just as we would a denial from an electronic remittance, that we key it as our reason and or remark code, and we pump it right into the workflow that we would for every other denial received electronically. Now, of course, the key here is related to denials is to make sure that we don't get them. Now, I know our economic reality is you're sitting across the table from a business, that is the payer, that has an economic incentive to deny your services. An economic incentive because that payer has already gotten the premium from your patient, its beneficiary, and the less of those premiums it has to shell out, the more money it has in its bank account. So it is a fight, it's a war, and you're going to battle every day to get paid. But the irony is sometimes we're battling against ourselves. And so I'm just going to ask you to go sit down with your team members in the business office and to say, what denials are you seeing over and over and over again? My goodness, you can pay some high-powered consultant to do it, but you can just go and sit down with your team member and say, okay, tell me, what are you working on over and over again? Because you will not believe the awesome information that he or she would have for you to take back to your front office, to your staff member who is scheduling surgeries and getting authorizations, who may not have realized that indeed Cigna has a totally different process or protocol related to advanced notifications that they now require. So that's just one example. Keep calm and prevent denials. That's really crucial to getting this overlooked opportunity in the business office. And what are we seeing on the horizon? We are seeing indeed automation coming in like a knight in shining armor to help us to understand how can we figure out not just staring at all these paper and electronic denials, but how can analytics, predictive analytics help us key in, hone in on which denials to be taking a look at? How should we prioritize these? Maybe I've got a health plan who, we can appeal this day in and day out, and they will never overturn it. So how can predictive analytics assist us with making sure that we prioritize our work correctly? This is very exciting. We're seeing a trend towards integration of predictive analytics in the revenue cycle, and it's something I believe we will continue to hear and read more about in the months and years to come. What we do have to make sure, predictive analytics or not, is that we recognize that, oh my goodness, every single employee in our practice is a member of the business office. In fact, I like to get name tags. Name tags, just wonderful little beautiful tags for our front office employees who are directors of denial prevention. Hello, directors of denial prevention. So let's figure out, just to sum up this overlooked opportunity, let's make sure we review our recommendations. We want to identify those source of denials, make sure we fix the problem, train our team members. Let's be transparent and make sure we review those denials with our physicians and or business owners, and making sure that we have ideally a physician, maybe an advanced practice provider, who is our denial champion. This would allow us to have somebody to go to, particularly about those kind of pesky medical necessity or denials related to experimental treatment that we may not know what to do with back in the business office. We discussed just briefly the integration of predictive analytics right on the horizon to have that help us in the revenue cycle, and then recognize that everyone contributes to success, not just our traditional billers. Now, I wish every service got paid, believe you me, but we just talked about denials. The other issue that we have, of course, is that our payers don't always pay us correctly. Now, I wish I could be standing here and saying, well, don't worry about it because the ones that pay you too low are offset by the ones who pay you too high. Ain't happening, y'all. I mean, you can look at this American Medical Association Health Insurer Report Card. Talk about giving one heartburn. Oh, my goodness. I mean, Medicare, we got to give it to Medicare. They pay, and they pay pretty much accurately 100% of the time. But look at these other payers. Oh, my goodness. And y'all, we're like, well, don't worry about it. Whatever's on the remittance, I mean, it is what we are supposed to get paid. So it worries me. I got to tell you, it worries me that we look at these remittances, or our system looks at these remittances, and we look at the amount billed, which of course in our language is our charge, and then we look at the amount allowed, and we're like, oh, been there, done that. We got it. That's right. That is the correct price. I'm going to ask you to think about, what is the correct price? Do we actually know what we're supposed to be getting paid? Because what we want to do is to load those prices, those allowables in our industry, right? Because they're not really a payment because it's what we are allowed to collect. You and I both know that those allowables, particularly on our commercial payer side, means we got to go chase that down from the patient. What are we allowed to collect by contract? And we want to load that into our practice management system. So our recommendations here are to obtain those allowables, to be sure we load them so we can confirm them. If we do not have the allowable correct, we want to look at that not at the claim level, but at the charge line item, the service level, and then we want to take action. If we didn't get paid correctly, particularly for a procedure or surgery, we want to make sure we put that into an appeal process, just as we would a fully denied claim. Or if we see an under-profile payment that is on really a bulk level. So there's a trend. We're seeing a lot of maybe our 99212s paid at $5 less than what our price, what our allowable is. Then we may want to go back to that payer and say, you know what, we've performed 130 of these in quarter 4, 2017, and so we're asking you to re-adjudicate all of these services. But please don't assume you are getting paid correctly. Now, we also know, regardless of all of this automation, that we have an opportunity to ensure our team members are doing the right thing. We talked about productivity standards, but I think it runs much deeper than that. We've got to find the right people to work as our team members, to hire right. I've heard all of these things in the business office. Oh, Elizabeth, if we just didn't have any patients, we could just do our job so well. Oh, Elizabeth, she's just so sweet. But, Elizabeth, we've always done it that way. Y'all have probably heard these lines and maybe some others, and sometimes I just shake my head, but I think about how many employees don't do the right thing. Some of it, of course, is out of ignorance. Maybe some of it's out of malice. I generally find that it's just, wow, I either have too much work to do or I indeed just don't understand how to do it correctly. One of the most important reports, in my opinion, in a business office is to run a 100% contractual adjustment report. This, in my opinion, helps you uncover where I find employees who may not be on the right track hide a lot of mistakes. Now, let me explain. When you are working accounts receivable, of course, the idea is to get it as low as possible, right? I want to have a low amount of AR. So as I'm working accounts receivable and I come upon, let's say it's a claim that was denied by United Healthcare, and I look at this and I go, well, I know this is going to take a letter. I got to go talk to the doctor. I got to go submit some form. I got to scan and fax. I got to do X, Y, and Z. It's a pretty laborious process. So I've got this procedure United has denied as experimental, and I got to work it. Or I could look at that and go, well, you know what? I need my AR to go down, and I know that I have 150 invoices that are still sitting on my desk that I have not worked. And so what I'm going to do right now is to take that denied service and to write it off as a contractual adjustment to United Healthcare. So if I write that off as a contractual adjustment, no one will ever find out that I did it. No one, right? Because we're like, oh, contractual adjustment. I mean, that's just a cost of doing business. Hello. We don't pull reports based on contractual adjustments. We assume that is the cost of doing business. And that's why I need y'all to be pulling a report that gives us those adjustments if they're at 100%. I've taken off the entire allowable. I've brought down the entire allowable down to zero as a contractual adjustment. That indeed, in my mind, would signal a problem with the employee, with the team member, or it's going to signal a problem where you're not getting paid by a payer routinely for those services, and that would warrant a discussion with the doctor, at least in my opinion. So we need to make sure we hire great, energetic, make it happen, multitask-oriented, right? I got my dual monitor. Every biller, of course, should have a dual monitor. If not, that needs to be at the top of your action plan, for goodness sakes. And an actual screen that you can read. I was in a business office recently, and they had like 11 by 13 screens. I can't even read the numbers on the screen, let alone get the work done in a timely and effective manner. Make sure that you really, really have great employees who know when to call a spade, and, hey, give employees a chance who have that fit but may not have worked in a billing office. Please make sure you invest in great team members and you get rid of the bad ones. Now, part of our problem, I know, is this course that was taught in medical school. Now, interestingly enough, I got married to a first-year medical student, still happen to be married to him, but, y'all, I went through all of this. He would come home and he would say, oh, you know, they taught us this, they taught us that, they taught us this, they taught us that. One practice management course. I don't know why, and I feel like people are still teaching this, Lesson number one in that course was the best way to make money is to reduce overhead. Lesson number two, the best way to reduce my overhead is to cut costs. And lesson number three, the best way to cut costs is to lay off or just not hire staff. I mean, have y'all seen these lessons for your physicians? Probably so. It's important for us to work with physicians and help them understand that overhead, and if you could see me, I'm making air quotes, overhead is a ratio. It is cost divided by revenue. And most of our costs are fixed. Now, that is, remember, our malpractice insurance, our IT expenses. Oh, my goodness, they're really difficult to cut. But when you do cut them, particularly if you cut team members, it impacts the infrastructure. And so once you impact the infrastructure, you can't create revenue, and ironically, the overhead goes up. Folks, it's all about return on investment. So when your doctor talks about overhead, please change his or her terminology to investments, And I actually like to bring this concept directly in the business office. And for us to take a look at each one of our workstations in the business office. So I mentioned, for example, our government payers and our commercial payers. So I like to take a look at each particular chair, each particular workstation of our team members, and determine how much am I spending, how much am I investing in that employee, as well as his or her overhead cost, and then how much is that employee returning to me. So it's our return on investment analysis. And this really helps us because what we quite often find is as we go through the chairs in the business office that we could have a better return on investment by making sure, for example, maybe we have a chair, a workstation, a team member who's calling patients all day long to collect on balances. Well, let's figure out if we're fully loaded paying him or her $40,000 and he or she is bringing in $38,000 per year, then we've got a problem, particularly when we look at the next workstation and we say, hey, our employees working government payers is sitting on 352 denials that nobody's worked. So this idea of return on investment and looking at workstations in the business office can help you help your physicians or your billing service really make some wise decisions about investing in the right things. So let's make sure we understand the concept of return on investment and we apply it. We've got a lot of things going against us, including that course in medical school that our doctors were taught. So move that term to investments when you work with your physicians. And make sure you invest in your revenue cycle. I love this quote I got from a great practice administrator. Elizabeth, we pay attention to cost, but we put our energy and our passion into our revenue. And that's an important one for us in the revenue cycle as well. Now let's end our overlooked opportunities with a big one. That indeed is patient collections. This is our 7th overlooked opportunity, and I generally find that we can start off with a discussion related to how much we spend on patient collections and really who we invest in. Now, I'm sure the United States Postal Service wouldn't want to hear me give this presentation because we are like literally the only industry left standing that sends invoices, statements through the mail. In fact, on a per provider basis, we spend about $8,500 sending out statements each year. If they worked, fine, great investment. But you and I both know that they don't. And it really didn't matter before because historically our patient financial accountability was so low that we pumped out a few statements and nobody really cared if anybody responded to them. Today, of course, that's very different. Our patient is our new payer. And indeed, we've got to have a great strategy to ensure we are successful in terms of performance. We, in my opinion, should give every patient a statement at checkout or whenever it is due. We don't want to send our statements at the 3rd or the 4th week or whenever our patient picks up on that alpha cycle. We want to make sure that our statements are dropping when that penny, that dollar is indeed due. So giving our patients statements at checkout when they have any sort of balance is a wonderful idea because it's free and you have the patient right there in front of you. At the very least, make sure that statement is transmitted exactly when it is due. We want to look at pretty much a tight patient collection cycle. I like to look at a 30, 60, 75-day final notice and then sending that account internally to our collections process or externally to a third party such as a collection agency to really begin collections. As you can see, we have 5 touches. That's a lot, particularly because we would have also asked the patient when they presented for an appointment, ideally during their appointment confirmation call, and then last but not least, when they call in for the appointment. Oh, Miss Woodcock, my computer tells me that you have a small balance. Can we go ahead and send you over to the business office to take care of that? Or I'm more than happy to accept a credit card over the phone. So please, again, make sure we talked about every employee being a member of the billing office. If we just rely on us back in the business office calling out patients and we ignore the fact that our phones ring off all day long, ring off the hook, calling up patients, inbound patients calling, then we're absolutely crazy. We're investing in the wrong things. So we've got to make sure we recognize that we have a great opportunity to really engage with our patients, and we should not stretch it much beyond that 90-day mark. Now, if you say, well, Elizabeth, I'm a referral-based specialty. I don't have the opportunity to schedule appointments, do appointment confirmation calls, to talk to patients when they present to my office. So what should I do? Instead of stretching out beyond the 90-day mark, my suggestion would be to send bi-monthly or twice-monthly statements. And so we still have those 90 days, but instead of 5 touches, maybe we increase that to 6 or 7 touches if we don't have that opportunity to be face-to-face with the patient. In fact, sending bi-monthly statements as well, I would recommend bi-monthly installments on our payment plans is a wonderful idea. The reason being, of course, is that that is how most Americans do get paid. Paychecks come on a bi-monthly basis, and so why we send out statements every 30 days? Well, it's totally beyond logic. And in fact, one of those statements that we made just a few minutes ago, all those team members who said, Elizabeth, that's the way we've always done it, that statement applies here. And there's no reason you can't change. And speaking of change, maybe even think about getting rid of those paper statements, the tether that we have to the United States Postal Service, just being done with it. Now, how do you do that effectively? You can tell the patient, so we're just not billing you anymore. We're not sending out statements and just go stone cold, sober, if you will, related to your statements. Or you can use this tactic that I love. Oh, Elizabeth, we're going green. If you want to be environmentally friendly with us, you'll accept our transition to electronic statements. We'll send a link to you, and you can go to our secure website and go ahead and see your statement, print it off, and pay online. What a great idea. But if you, Ms. Woodcock, don't want to go green with us, then we do have a nominal service charge to continue to send you paper statements. Now, y'all, this is just one way to convert to the electronic environment, but I think it's a great one to take a look at. So please, regardless of how you do it, consider in the next 12 to 18 months migrating to a secure electronic platform with online bill payment for your patients. It's a great investment to make in your practice. So our recommendations for this final 7th overlooked opportunity to redesign your collection process, to look at that 90-day suggestion. If you don't want to look at more than 5 touches, then to consider moving it to a bi-monthly or twice-monthly process. And to really focus our efforts on moving away from a reliance on paper statements and to move right into the electronic environment. Goodness gracious, the phone company, electricity, everybody else is on that platform today, so why not us? So let's take a look at those recommendations. And in conclusion, we have our 7 overlooked opportunities. To take a look at charge capture, Workqueue Management, looking at our denials, our underprofile payments, hiring the right team members, making sure we work with our physicians on overhead and changing the mindset to investments, and last but not least, to look at patient collections, to invest in our cycle, and to perhaps even look at migrating to an electronic environment. Well, y'all, I hope you've had the opportunity to really focus in on those 3 ideas that I suggested at the beginning of our webinar, and to create an action plan where you can take those 3 ideas, or maybe you've even found more, and to turn that truly idea into a plan and to act upon it. Colby, I'll take the opportunity to turn our webinar back to you so we can move into our Q&A session.
Well, thank you so much, Elizabeth. That was amazing. Great energy and a lot of really great information. Indeed, we are moving into the Q&A here. We'd like to open it up for questions from our live audience now. Elizabeth, one coming from your presenter here. I'd like to just tie this in even with an enhanced medical billing service or an RCM, much like quantum RCM, and just think about some of these 7 overlooked opportunities and how some of these stresses can absolutely be assuaged by a proper software platform that helps you address things like denials and whatnot. And if you have any insight into that as well, into successes in using a professional medical billing software.
Yeah, I think it's a really great point because, many of these we talked about really require some insight, some business intelligence. And so if you don't have the platform to support that business intelligence, it's very difficult to know, how do I prioritize? How do I invest most effectively? And so what you've brought up is so critical, is to be able to have really the infrastructure from which to launch these ideas from. Really, really great point, Colby.
Excellent. We do have one question that came in, and I'll paraphrase it a bit, but it's essentially asking about incentivizing the reduction of denials, asking about ways to motivate staff to help to chase down denials a bit more, and if you have heard of specific ways of motivating them, whether it be through prize or opportunity or even in a pay vig or anything like that.
Yeah, that's a great question from our attendee, and I would suggest, again, starts with really the data, because if we're just like, oh, you did better, it just, team members really don't respond to that, just like I wouldn't respond to that. So starting off with data, I think having, that sort of old school thermometer in the business office, maybe you go for that, but you put it electronically, so you really measure success. That might be the number of denials, it might be dollar amounts, measuring success, really displaying that data, I believe is very, very important and really requires a great platform, an RCM platform to launch those efforts on. And then, you want to get some real fun in there. You could do payday bars for everybody, or love to do that. Have the green team really be your work group to look at these denial opportunities, and everybody gets a green team shirt that they can wear on Fridays, who's involved with this task force or work group. So in my opinion, I love to have fun. I'm not really sure that, doing, some report every Monday morning is really going to be effective if you don't have some energy and passion behind it. And there's a lot of really fun ways that you can do that in billing. I named just a few. And very importantly, thank your team members. Oh my goodness, it's just amazing to me how often I find employees say, you know, the doctor doesn't even know my name. So please, just those basics, make sure when you do any sort of performance improvement opportunity, including denials, be transparent, have the data, make it fun, and make sure you show employees appreciation. Colby?
We do have one more question here that I'd like to put to you before moving on. It does say, I'll give you the full text from it. It says, awesome webinar, thank you. Any suggestions on how to go green, and are there specific vendors or programs that implement paperless statements specifically?
Well, the idea that we talked about in terms of going green, I think is a great one. I even provided that letter that y'all are welcome to use, and you could do that when patients actually present to the office. Another great thing is to begin to migrate to that process by placing mailers within your existing statements, you know, just to say, by the way, this is the last paper statement you'll receive because January 1st, 2018, we're moving to a paperless environment. Now, in terms of the actual vendors, definitely want to make sure that you have someone who can deliver a very, very secure environment. So this is absolutely critical. So you want to have someone with experience as well as a vendor that you trust and ideally connected to your practice management system. Because if you have to really have two different systems that you're working in and out of, it makes everything from just daily close to making sure accuracy is there, as well as being efficient in terms of your team members. Really, you want to make sure you have a seamless solution. So again, really some ideas about moving, having that letter, introducing it in a statement mailer that you might have today, and then making sure you go with a trusted vendor and a seamless solution. Colby?
All right. Just a quick note to let you all know, all of the attendees, that the slide deck and the recording will be made available to you after the session, so do keep an eye on your email for that. As well, we'll make sure to follow up with information on obtaining your CEUs for credit as necessary, as this was a credit available course, which we're very excited about as well. Elizabeth's contact info is on the screen now, and if we didn't get to your question today, we'll follow up with you offline. And Elizabeth, thank you so much once again for your presentation today. Now turn our attention to our sponsor, the Quantum Healthcare IT portfolio. Quest Quantum offers a complete end-to-end solution for all of your practice needs. We focus on the business side of things so that you can focus on your patients. We connect healthcare organizations, community physicians, and patients to improve access to information and insights. Our applications work harmoniously to promote physician loyalty, provider collaboration, and positive patient outcomes. And because we're backed by Quest Diagnostics, you know that you can rely on a stable and proven partner. Our network is strong, connecting over 470,000 clinicians and touching the lives of over a third of all Americans every year. The confidence and reliability that comes standard with every Quest Diagnostics relationship is easy to appreciate and to benefit from. And our holistic suite covers every aspect of your patient and practice lifecycle, from appointments and reminders, documenting a patient visit, verifying insurance and processing payments, and right through integrated follow-ups via the MyQuest patient portal. If you're looking for a complete solution from a single source, we have you covered. Our electronic health record is an ONC-certified, award-winning product that works extremely well with small practices like yours. It's cloud-based with powerful mobile integration to your smartphone or iPad, allowing you to work wherever and whenever it's convenient for you. The practice management side allows your front office to work more efficiently to manage the flow of patients, keeping your practice organized and agile, linking directly to your EHR so that you can spend more time focusing on your patient and billable encounters instead of front office administration. If you're considering an enhanced medical billing service, Quantum RCM is an outstanding revenue cycle management product as well. Few things are as time-consuming for your practice as billing and collections, and handing off the more monotonous busy work can free your staff to focus on patients instead of spreadsheets. And you can trust us to provide you with a solution that's up to date on the evolving trends and the changes in the industry. And they can address the very concerns that were brought up in today's webinar. If you have more questions about the Quantum Healthcare IT portfolio, please feel free to call or email using the contact information on the screen. And once again, we thank you all for your attendance today, and a very special thanks to Elizabeth Woodcock and, of course, to Quest Quantum for sponsoring the event. Keep an eye on your email inbox for additional seminars covering related issues in the near future. And this will conclude today's presentation.